Greetings and welcome. This recorded session is on how to use PRAPARE to assess and address social determinants of health needs. My name is Nalani Tarrant, Deputy Director of Research Projects at the National Association of Community Health Centers, also known as NACHC for short. And you'll also hear from my colleagues today, Sarah Halpin, the Program Associate, and Eurico de la Cruz, Social Determinants of Health Manager. While you'll be hearing from the NACHC staff today, I also want to point out that this has been a long-standing partnership with the National Association of Community Health Centers, the Association of Asian Pacific Community Health Organizations, and the Oregon Primary Care Association. From this session, you will understand how PRAPARE enables folks to better understand patient complexity, address social risks, and demonstrate value, be able to identify workflows, tips, and strategies for effectively implementing PRAPARE, and hear examples of how PRAPARE has led to changes at the patient, organization, and community levels. To help set the stage, I will begin with a quick overview of social determinants of health. So there are lots of terms that we use within the healthcare world, and it's always good to take a step back and define these terms we use. It can get confusing, especially since a lot of these terms we use are interchangeable. Social determinants of health is defined as the conditions in which people are born, grow, live, work, and age. These conditions are shaped by the distribution of money, power, and resources. Social risk factors are specific adverse social conditions that are associated with poor health. Social needs refers to the patient's role in identifying and prioritizing social interventions, and population health is the health outcomes of a group of individuals, including the distribution of such outcomes within the group. So these terms are all interconnected, but each means something different. So hopefully this provides some context as we move along in this presentation. As a driver of health inequities, social determinants of health have shown a greater impact on population health and individual well-being than factors such as biology, behavior, and medical care. Medical care, although essential for health, has shown to be a relatively weak influencer of health in that it has been estimated to account for only 20% of the modifiable contributors to health outcomes for a population. The other 80 to 90% have been attributed to social, economic, and environmental factors referred to social determinants of health. So as we saw in the last diagram, social determinants of health can encompass social economic conditions, environmental conditions, institutional power, and social networks. These factors exist upstream in that they occur and interrelate with each other to ultimately influence characteristics that manifest further downstream, such as health behaviors, health conditions, and health outcomes. While some social determinants of health are within an individual's control, many lay outside an individual's control, ultimately impacting their health outcomes. So this leads us to here. Why collect social determinants of health data, and specifically, why collect standardized data on social determinants of health? Health centers and others are increasing their use of social risk screening tools, such as PRAPARE, to better understand, document, and address the root causes of not just poor health, but of inequities. Having this data integrated into systems can allow teams internally and externally to collaborate to proactively assess and address client social risks, and can also be used to guide local partnerships to accelerate alignment. This diagram provides examples of use cases of social intervention documentation from the patient to the policy level in alignment with this vision. So now I'd like to move on into understanding our PRAPARE screening tool. And at this time, I'll go ahead and hand things over to my colleague, Sarah Halpin.
Thank you, Nalani. We can go to the next slide. PRAPARE is the protocol for responding to and assessing patients' assets, risks, and experiences, and it's a national standardized patient risk assessment protocol designed to engage patients in assessing and addressing their social determinants of health. In developing PRAPARE, NAC, APJO, and OPCA came together and reviewed existing protocols, considering patient and provider experience, incorporated stakeholder feedback, and identified the 16 core social determinants of health to be assessed using PRAPARE. Along the way, the PRAPARE team ensured that PRAPARE would align with key national initiatives, including Healthy People 2020, ICD-10, IOM, Meaningful Use Stage 3, and NQF on risk adjustment. Here you can see all of the information that is collected when using PRAPARE. The core data set is what we think a health center would need to know about their patient population to best serve them. And those highlighted in red are questions that are often collected elsewhere in registration forms and for UDS reporting, so health centers can avoid duplication there. We also think having the core set of data at the state and national level will help us better tell the health center story, what makes health centers unique and valuable, and use that for policy and educational purposes. PRAPARE users can choose to add on optional and optional granular questions depending on their patient population and their needs. The main focus of PRAPARE is on standardizing the need rather than standardizing the question. You may collect some of this information in other parts of your workflow or EHR or PMS, and that's fine. It's not so much about how the data is gathered, but that the data collected is standardized. We want health centers to have valuable data to allow them to better understand and serve their patients. And this can lead to a lot of different approaches. You can start with just a few of the questions to test out different workflows. Some health centers focus on questions that align with the Accountable Healthcare Communities model. Some health centers are focusing on those SDOH that they already think have a large impact on their patient populations, though many health centers tell us that PRAPARE has helped them uncover new needs that they hadn't known about. All this to say, feel free to start small and incrementally work PRAPARE questions into your workflow as you and your team feel comfortable. We have a plethora of resources available to support you on your PRAPARE journey. The PRAPARE tool can be used as a paper handout or implemented into the EHR. The PRAPARE Readiness Assessment tool can help identify your organization's readiness to implement PRAPARE. PRAPARE Implementation and Action Toolkit provides resources, promising practices, and lessons learned to guide implementation, data collection, and responses to social determinant needs. EHR templates are available for free after signing an end user license agreement available on our website. PRAPARE is available in more than 25 languages with translations validated at community health centers for comprehension and cultural competence. And finally, coding. Many PRAPARE EHR templates have used crosswalks to map PRAPARE measures to ICD-10 codes, LOINC, and SNOMED. Interest in PRAPARE continues to grow by the day. Organizations like using PRAPARE for the following reasons. It's actionable. PRAPARE has a free implementation and action toolkit to support users to implement PRAPARE and take on actions to address patients' social needs. PRAPARE can fit into any care setting. It's workflow agnostic, aligns with ICD-10 codes, LOINC, and SNOMED, and is available in multiple EHRs. It's standardized and widely used. It has measures linked with standardized codes. It's the dominant SDOH risk screening tool used by health centers and Medicaid managed care organizations, and it standardizes the need rather than the question, so it's flexible. It's also evidence-based and stakeholder-driven. PRAPARE was informed by the existing evidence base on social risk and national efforts to address social risk, and it was also built, vetted, and tested with health centers and healthcare organizations across the country. It was designed to accelerate systemic change. PRAPARE data can be used to show patient complexity throughout the development of risk stratification formulas, and it ensures the ability to better target complex patient needs in terms of enabling services such as referrals and case management. And finally, and perhaps most importantly, it's patient-centered. So it's meant to facilitate conversations and build relationships with patients. And again, it's translated in over 25 languages and has a decline to answer option for all questions to respect patients' choice to respond. There are many opportunities to leverage PRAPARE beyond the provision of care including payment reform efforts, community health worker initiatives, and more. And as you work to gain buy-in, consider your organization's priorities and how they can be strengthened by having rich STUH data. Here we have a map illustrating PRAPARE use across the US and FQHCs using 2019 UDS data. And we're currently updating this with the new 2020 data that's just come out. If you'd like to learn more about the number and percentage of PRAPARE users in your state, we encourage you all to check out the link, which will take you to an interactive version of this map. We are really proud to see so many health centers screening for social risk factors and that their standardized screener of choice is PRAPARE. Again, while this data is from the 2019 UDS, we're seeing the same trends in 2020, with PRAPARE being the dominant screening tool even during COVID. If you'd like to learn more about PRAPARE and see some examples of PRAPARE in action, we encourage you all to check out Chapter 1 of the Implementation and Action Toolkit. And now I'd like to hand it over to my colleague, Yuriko de la Cruz, to share a bit more PRAPARE implementation and stakeholder engagement information.
Thanks so much, Sarah. So building capacity to address the social determinants of health begins with an assessment of your organization's current capacity. What resources does your organization have available to focus on addressing identified needs, and in what context do these resources exist? Are they internal to your organization, or do they exist outside of your organization? Consider the following resource categories when you assess resources within your own organization to address the social determinant health needs. These include people, processes, and technology. With any new initiative, it is important to engage stakeholders who have an interest in the success of the project. Involving people who will be impacted by the initiative can lead to strong support of the project and can strengthen the process and/or outcomes of the project. For example, engaging staff can lead to the development of more appropriate workflows to collect and act on the social needs data. Engaging patients can lead to more appropriate interventions or community partnerships. There are many ways to engage stakeholders, ranging from education and consultation to direct involvement in the project process. Some stakeholders may desire and have the capability of engaging in a more active and direct way, such as helping to define priorities, collect the data, interpret the findings, and act on the data. It also allows for developing community advocacy plans as well. Our stakeholders may desire or only have the capability to engage in a more passive way, such as attending meetings or providing feedback. What is more important is engaging and educating stakeholders so that they can take an informed decision as to how they would like to be engaged. And these are just an example of some steps to engage stakeholders. Engaging stakeholders begins with messaging. Before asking staff, leadership, and patients to collect and provide personal and sensitive information, it is important to educate all stakeholders on the importance of collecting data on the social determinants of health and how that information will inform care and services. It is also important to emphasize how this work adds value to other work in which the organization is involved, so that it does not come across as an isolated one-off project, but one that fits into the organization's larger overarching goals. And these are some great examples to get you started. Getting started with the new process or making changes always comes with challenges. As leaders, we want to make sure to both identify and address these challenges. These are the most common challenges PRAPARE users have shared with us. In addition, they provided some responses to these challenges. You can learn more about the messaging and sample scripts within Chapter 2 of the Implementation Manual. So after gaining an understanding of the project and engaging your stakeholders, it is important to think about how to strategize the PRAPARE data collection to fit within your overall organizational vision, workflow, and future strategy. The 5 Rights Clinical Decision Support is a key health information technology framework that can help in planning, PRAPARE workflow, and implementation in your practice. Based on this framework, implementation must provide the following to improve targeted health outcomes, quality of care, efficiency, and cost savings. Consider these questions. What information in PRAPARE do you already collect? How are we collecting this information, and in what manner are we collecting it? Who will collect the data? and who will access the EHR to input the data? Who also needs to see the information to inform care as well? Where are we collecting this information? And where do we need to share and display this information? And finally, when is the right time to collect this information so as to minimize disruption to the clinic workflow? These are some great tips from PRAPARE users that can help you get started. Starting small allows you to work out any issues in the workflow, dispel common myths or concerns, and use findings and lessons learned to educate others on how prepared data can be used to encourage more buy-in. The PDSA framework is a great tool, and this will guide you in testing changes in real-world practice settings by planning the change, testing the change, observing the results, and acting on what is learned. Next, populations of focus may be determined by the organization's objectives and by staff ability and workflow alignment, or by project deliverables. Common populations of focus include patients with diabetes or hypertension, patients receiving care management, or even partnering with one specific clinician in your practice. Work plans are critical to keep efforts organized with key milestones, tasks, roles, and deadlines. This is a great tool for you and your organization to use. This could also align and should be aligned with your organizational goals, which allows health centers to identify their baseline and then their targets for growth. Next, as new initiatives take place, organizational updates are helpful for everyone to understand the progress and learnings from staff that are using PRAPARE. And then finally, celebrate every milestone and achievement to recognize your staff, their hard work, and the impact on addressing the social needs of patients by using PRAPARE. Chapters 3 and 5 are filled with so many resources that can help you and your team get started on implementing PRAPARE. These are just some of the highlights of the resources that you will find in these 2 amazing chapters. As mentioned earlier, we have EHR templates. There are several EHR templates currently available, including CW, Athena Practice, and NextGen. To access the free PRAPARE EHR templates, first sign the end user license agreement, and that can be found on our website. And for those who use an EHR where PRAPARE template does not currently exist, we also have an Excel file template that allows you to collect standardized PRAPARE data in Excel until a PRAPARE EHR template is developed. If you have any questions, please feel free to reach out to our team. Next, I'd like to talk about some of the amazing work done within our health centers. So back in May of 2020, the PRAPARE team had a virtual town hall with PRAPARE pioneers about the impact of COVID-19 on their ability to screen and address social needs of patients. Dr. Via Segal was invited to share how her and her team at NACHC Comprehensive Health Center had been reaching out to vulnerable populations at the beginning of the pandemic. During the town hall, she shared how her team were able to use PRAPARE for targeted outreach. Next, we have Siouxland Community Health Center, which was featured in the local news for their efforts with using PRAPARE to identify social needs of patients. This article tells the story of a patient and the case manager who partnered in identifying his needs. Siouxland is one of the PRAPARE pioneers who piloted the screening tool, and they have since continued to lead efforts on using PRAPARE data within the health center and their community. The PRAPARE team is grateful for all the hard work and innovation that has occurred amongst health centers. We encourage you to take a moment to check out these amazing case studies that were harvested through our Engagement and Innovation Awards. Thank you for your time. If you have any questions or want more information on PRAPARE, please be sure to email us at prapare@nac.org.